The extra-articular wrist clamp was especially designed for extra-articular non-bridging application of the penning wrist fixator. Indications include metaphyseal fractures in the distal radius without articular involvement and meta and diphyseal compound fractures of the radius with or without bone loss. Lister's tubercle is identified and exposed. The 1.5 or 1.6 millimeter Kirschner wire is inserted at an angle of about 45 degrees to the frontal plane. A template with handle with one pilot wire guide is slid over the Kirschner wire after the position has been checked radiographically. The second pilot wire guide is placed inside the second screw guide. A second Kirschner wire is inserted parallel to the first in the area of the radial styloid. During insertion, it's recommended to aim for the solid cortex of the volar lip, but care should be taken to avoid penetration of the volar structures. The pilot wire guide in Lister's tubercle is exchanged for a 2.7 millimeter drill guide and the Kirschner wire removed. Pre-drilling is carried out with a 2.7 millimeter drill bit and an 35 millimeter screw inserted. The second Kirschner wire is now removed, and after pre-drilling, a 20 millimeter screw is inserted. The screw should engage the volar cortex securely and penetrate by one thread. Penetration of the radio-ulnar joint, however, must be avoided. The radiolucent T-clamp allows variable pin placement in the radial epiphysis. Whereas the parallel insertion is recommended in routine cases, convergent insertion of the bone screws may be required in small epiphyses. In this case, after insertion of the Kirschner wire in Lister's tubercle, the radiolucent T-clamp with the pilot wire guide is slid over it. The second pilot wire guide is inserted, and after exposing the bone, a second Kirschner wire aiming at the volar lip is placed. The screw guides and drill guides are used with the radiolucent clamp acting as its own template to replace the Kirschner wires with the appropriate screws after pre-drilling. Insertion of the proximal screws is carried out at a distance of about 14 centimeters from the distal screws. The fixator may be mounted temporarily on the distal screws to indicate a good position for the proximal screws. The screws are inserted through a 25 millimeter incision in order to avoid injury to the superficial branch of the radial nerve or tendons. After pre-drilling with a 2.7 millimeter drill bit, in most cases 20 millimeter screws will be employed. Reduction of the fracture is carried out after preliminary tightening of the radiolucent T-clamp and proximal clamp to the bone screws, with the double ball joint and the clamp anchoring screws loose. Both ball joint security collars should be fully tightened at this point. After reduction of the fracture, the central screw of the radiolucent template is tightened first. The screws are fully fastened once the Allen key slips inside the hexagonal. The additional holes in the screw head are used to unfasten the screws at removal. The remaining fixator components are then tightened, with the cams of the double ball joint being rotated clockwise. Fracture types which may be treated by this technique include AO type A2 and A3 metaphyseal fractures, which correspond to Frickman 1 and 2, as well as 5 and 6 fractures. An intact volar and dorsal cortex of 1 centimeter has to be present for secure pin placement in the volar lip. A distal radius and ulnar fracture is treated here in a 28-year-old female. The operation is performed on a hand table and a tourniquet should be used. The wrist is placed in the neutral position. After identification of Lister's tubercle, a 1 centimeter incision is made and the bone exposed. Care has to be taken to avoid injury to the extensor pollicis tendon, which is on the ulnar side of Lister's tubercle. From the radial side, a 1.5 or 1.6 millimeter Kirschner wire is inserted obliquely, aiming at the volar lip. Correct positioning of the Kirschner wire is checked radiographically in both planes. Penetration of the radio-ulnar joint must be avoided. The position of the second Kirschner wire is marked on the skin with the help of the template handle. And again the bone on the radial styloid is exposed through a 1 centimeter incision. Care must be taken to avoid any injury to the superficial branch of the radial nerve. A second Kirschner wire is advanced towards the volar lip and checked radiographically. With the pilot wire guide over the second Kirschner wire, a drill guide is placed in the longer screw guide over the Kirschner wire at Lister's tubercle. This Kirschner wire is removed and after pre-drilling, an 35 millimeter screw is inserted. The second Kirschner wire is replaced in the same way, and usually a 70-20 millimeter screw is inserted in the radial styloid, just penetrating the volar lip. Correct screw positioning is verified radiographically in both planes. The radiolucent T-clamp allows variable pin placement, whereas in standard situations, parallel pin placement in the distal radial epiphysis is recommended. Converging insertion may be advisable in a smaller epiphysis. Insertion of the proximal screws is carried out at a distance of about 14 centimeters from the distal screws through a 25 millimeter incision. The bone must be exposed and injury to the superficial branch of the radial nerve carefully avoided. After detaching the periosteum, the template handle with the screw guide is inserted. After pre-drilling, a 70-20 millimeter screw is placed.
wäre aber ein unmarkierter gewesen.
Ja?
Mhm.
The penetration of the opposite cortex is checked radiographically. The screws must not be advanced too far, since due to their tapered design, they may not be backed out. Irrigation of the incision helps to wash out bone chips and is recommended for all pin sites. The fixator is now slid over the bone screws and the central screw of the radiolucent T-clamp tightened first to avoid angulation of the clamp cover. The security collars of the double ball joint must be fully tightened while the cams are loose. Fracture reduction is carried out and the position checked radiographically. The radiographs demonstrate the radiolucency of the T-clamp. Tightening of the cams in a clockwise direction is performed. The clamp cover and the clamp anchoring screws are finally tightened. The distal ulnar fracture was found to be unstable in this case, and a medium FFS implant was used for one-step fracture fixation percutaneously. Subcutaneous suturing of the proximal incision is carried out and no tethering of the skin around the distal screws is allowed. Simple dressings around the pin sites are recommended. Circumferential dressings are not advisable. Flexion and extension and pro and supination are possible with this fixator design from day one. Physiotherapy is recommended, but painful exercises should be avoided. The fixator remains in situ until bony union, on average between 5 and 6 weeks.